One of the reasons I think protocols are important, beyond not, just the patient, is that we did a study going backward to see how long it took from the time landmark evidence is produced in healthcare for it to become standard of practice with physicians. It takes 17 years. It takes 17 years. And a great example I always use about this is just more recently, Medco's very much into pharmacogenomics and the use of genetics to dose people uniquely at the personal level. We're doing a venture right now with the Mayo Clinic around the dangerous drug called Coumadin. Coumadin's a blood thinner. It's the most widely used blood thinner out there. It's the same compound that's in rat poison. It thins your blood very effectively. However, we all metabolize it differently. And the stats are today, the doctors will start you on a 5 milligram dose. It will take them 6 months to adjust the dose to your unique chemistry, your unique genetics. And in that 6-month period, 22% of people will be admitted to a hospital with a serious bleed or a clot because the dose wasn't right in that 6-month period. 22%, that's a huge number. And so what we're doing with the Mayo is on first starts of Coumadin, we're doing a genetic test. And we'll be publishing our results with the Mayo toward the end of the year, but I can already tell you a couple of interesting findings. The guidance label on the box of Coumadin was changed to you should consider a genetic test before doing this in August of 2007. That news was a big deal. It was in the Wall Street Journal, the New York Times, JAMA, the New England Journal of Medicine. You would think everybody knew it, but in March of 2008, we started calling doctors to order the genetic test tied to this pilot. It was free, didn't cost anybody anything. This was a study. And you'd be surprised, out of 1,000 doctors with such a widely publicized situation, only 3 in 1,000 had ever heard of the test. 3 in 1,000. That scared me a little bit. And another example is Tamoxifen. 10% of women can't metabolize Tamoxifen. It's the most commonly used drug to prevent the recurrence of breast cancer, and the stats are clear. If you don't take a drug after you've had breast cancer, your chance of getting metastatic breast cancer the second time is very high. So you should be on a drug that works. But 10% of people can't metabolize Tamoxifen. They should, especially if they're postmenopausal, they should be on a different drug that's available. Well, it turns out 1 in 100 doctors does the genetic test on this. So you have women taking Tamoxifen thinking they're doing the right thing, and they could take M&Ms and it would have the same effect. And to me, waiting 17 years for that to become standard of practice, and by the way, that test has been around 5 years. There's something wrong with that, and it's another reason I believe if we want to elevate the game in healthcare, a wired system where the most current protocols are available and we can measure performance off of those protocols is fundamentally important, and we can do it today.